Thank you for the invitation, and it's really my pleasure to be here today talking about DCUS for assessing the response to anti-angiogenic treatment of solid neoplasia and to present the state of the art. I may start by saying that on 2018, according to the American Cancer Society and the American Society of Clinical Oncology, the number of new diagnoses of cancer was estimated to about 1.7 million, and the cancer-related death to more than 600,000. The global burden of cancer is expected to grow in the future, reaching about 21 million new diagnoses of cancer and 30 million cancer-related deaths by 2013 as the world population expands and age. These sobering statistics underscore the emergency of finding better treatment for patients today and in the future. The increase of number of new FDA approvals in oncology is reflective of the scientific fervor for this subject to fill in this need. For example, from November 2016 throughout October 2017, the FDA approved a record 18 new cancer therapies and 13 new uses of cancer therapy. By the same period, from November 2015 to October 2016, 8 new cancer therapy and 13 new uses were approved. All this new use and new therapy were based on the improvement in patient survival and or quality of life. Thus, the tremendous increased number of enemies oblige us to increase and multiply the attack angle. For that, and during year, new treatments are appearing, especially which is going to be our topic today, anti-angiogenetics. What is our role as imagers, though? I was planning to say that in this adventure of anti-cancer, in this anti-cancer adventure, if oncologists were Indiana Jones, we are definitely their torch, because we are here to show them, to enlighten their way, to tell them if they should continue or stop or change their treatment. And yesterday, while discussing with Annalisa, I figured out a better word and created a logo for it. We are ultra sun. I mean, we are here to create and to applicate criteria to facilitate the standardization of exam and report in order to improve the reliability of result for clinician. For that, WHO criteria, RECIST 1.0 and then RECIST 1.1 criteria have been established. The problem is with the development of new drugs, these morphological criteria showed quickly their limits, and literature started to require new functional imaging methods and declare them to be necessary. Why do we need tumoral functional evaluation? It's because new treatment in oncology, especially those who targeting angiogenesis, induce destruction of neovascularization and necrosis, often without volume changes. Thus, if I take this example, before treatment, we can see a large enhanced tissular part. Okay, thank you. We can see a large enhanced part, peripheral part. After treatment, we can see that the size of the lesion has not changed, but the aspect and the density inside the lesion have changed. The size criteria essentially reflect cytotoxic effect and do not take necessarily account of changes in internal structure. Thus, WHO criteria or RECIST criteria are unsuitable, and this have been mentioned in the literature very soon, since 2004 and 2006. So, our alternative is dynamic acquisition during injection of contrasound-specific agent, which is DCUS, with a particularity, that is, ultrasound presents the best temporal resolution compared to DCES, MRI, or CT. As it have been said yesterday, contrast agent on ecography have an intravascular spread. So we can't study all the parameters that we can study in MRI or in CT, but we can have information about time to peak, wash-in time, peak intensity, time for full width, half max, area under curve, and area wash-in and wash-out. These criteria are the result of the study of the move of the contrast in the vessel. So the question that naturally comes in our mind is, first of all, the reliability of this technique, the existence or not of intra-observal variation, if a specific procedure of injection is necessary, is there any parameter from those I've cited that is reliable? If there's one criteria, what is the cutoff that we choose, and in which delay we should evaluate our patient? Finally, and at the beginning, no consensus. There were no consensus about the parameter or the timing for the early evaluation of anti-angiogenic drug, nor for the cutoff. DCUS, like CT perfusion or MRI perfusion, was a little bit foggy. So the key point was this standardization, and that was our point and our purpose. A French national program of DCUS was led from 2007 to 2009 and aimed to extend and validate our methodology using raw linear data, also to demonstrate the feasibility of DCES in 19 hospital centers in France. The goal was to determine which is the best parameter, which cutoff we should choose, which timing is decisive for evaluating response to anti-angiogenic therapy, and to assess the economic impact of DCES throughout a prospective cost study. Patients were included by the moment they were treated by anti-angiogenic therapy, regardless to their primitive cancer. It could be patient with metastasis or with primary lesion. All patients have been evaluated with DCUS at baseline, day 0, after 7 days, at day 15, at 1 month, and at 2 months. Also, 2 patients has a CT scan and an evaluation based on RECIST criteria performed at baseline and every 2 months. Here is a summary of the methodology we adopted and we suggest for quantification and evaluation of tumor response. In the 19 centers that participated to the study, all have been working on a Toshiba machine disposing from 2 probes dependent of the type of the target, if it was superficial or not, with 2 settings. In every patient, 1 target clearly defined was selected. All patients have a bolus injection of Sonoview of about 4.8 millimeter. The choice of Sonoview was because in France it's the only product that have the license, and it's the only product that we use. Then, for 3 minutes systematically, from the instant 0 of the injection, we do an acquisition of raw data for 3 minutes. This is the parameter that have been automatically put in the machine. I mean, by the moment you put on, the machine will take 3 minutes of raw data. Then, this raw data will be treated by an engineer that will perform a quantification, a modelization, and give us an evaluation of the 7 parameters that I have been talking about. In fact, in our practical life even now, what we do, there is 3 times, I'm going to say. First time, it's the acquisition of images. And if I may advise something, is to keep your eyes on your target, regardless to what happens. Don't try to get information at the beginning. The most important is to have a reliable image, a target that stays from the beginning to the end visible and with a quite good signal so that we can analyze it. Then, the second time, we as radiologists, we write a first report based on our visual evaluation. We say, for example, the lesion is seen on 2D mode. It measures x per x per x, and the enhancement measured is about 80%, 90%, 100%. And then the engineer gives us a real number, a quantitative number based on the curve and the modelization extracted from raw data. We finish our inclusion on March 2010 for a total of about 539 patients and about 2,069 US examinations that have been analyzed, regardless of histologic type, as I said, and regardless also of localization of target lesion, although the majority, more than half, were liver lesion. This multicentric study allows us to go through a standardization of dynamic contrast enhanced ultrasound. 5 criteria were found to have a major impact on quality, which were lesion size, motion, loss of target, border, and total acquisition in wash-in. And only 3% of the examination were of poor quality, which is interesting to see that the quality of the examination was directly related to radiologist experience and significantly higher if the radiologists have done at least 60 DCUS examination, which is a good number because 60 is not so much to have a good learning curve and to use this technique. After this study, Euroson published guidelines and good practical recommendation for use of contrast ultrasound in the liver with a special item for contrast quantification and monitoring systemic treatment of malignancies. It was in fact the third iteration of recommendation. First were published in 2004 and the first update was on 2008 and the third update was on 2012. These guidelines and recommendations provide general advice on the use of all currently clinical available ultrasound contrast agent, and they intend to create standard protocol for the use and administration of contrast agent in liver application. For that, all items, methodology and equipment for quantification, data acquisition, quantification of software, administration of contrast ultrasound, and assessment of anti-angiogenic treatment were treated in these guidelines. Besides, from the same study, here is a table that summarizes the statistical significance of the correlation between DCUS parameter and TTP at 12 months. Voluntarily, we have just taken the significant value. I need to mention that the p-value are significant even if we apply a Bonferroni correction to take into account multiple testing. Don't ask me what is it. This is what my statistics said. And we can say, on the basis of this result, that 2 criteria appear to be interesting to study: the variation of the area under curve and the day 13. And that's the 2 criteria that we for which we go further in our studies. I show you here a graph representing the overall survival in the 2 classes defined by the cut point selected for the variation of area under curve. We see here the patient, the black curve, the patient that have that have a decrease of more than 40% of area under curve, and the patients that have not in the red curve, and we see a better survival in patients that present a decrease of area under curve. Thus, we agreed that the decrease of area under curve more than 40% at 1 month is predictive of response. This was the result, the first result published on our multicentric study. Afterward, 5 monocentric study realized in our institute and another institute confirmed these results with different histological type and different anti-angiogenic treatment. It's always the area under curve, a decrease more than 40% evaluated at 1 month. Finally, we could validate the dynamic contrast-enhanced ultrasound in predicting outcomes of anti-angiogenic therapy for solid tumor with a technique that is cost-effective, safe, repeatable, and quite easy to learn if we consider the learning curve of 60 exam. Let me present you a case of a 56-year-old female patient treated for a sarcoma. The treatment began on the 12th February, and the target lesion was a right limb sarcoma, the lesion that you can see here on 2T imaging. This is the kind of analysis and the platform, the platform that we have to analyze the raw data information. As you can see, the engineer aged the tumor and study its enhancement, considering the time, and give us a curve. We, as radiologists, initially analyze this lesion, give it measurement in the report, and say, for example, this lesion enhanced about 90%, and wait for the result of the engineer. Okay, this is my, this was my in case of image. Day 19, this patient had again a control. Size was almost the same, maybe grew a little bit. Vascularization maybe is different here, but it's difficult to evaluate just by looking at it. At 1 month, control, size seems to be more important than at the beginning, but when we see the behavior of the lesion, I may just can't be quicker, sorry. You can see that this part of the lesion is not enhanced. As a radiologist, we'll write a first report. We say like that visual enhancement is about 50%. There is decrease. And we need to confirm it. I'll show you the day 1 month and the baseline. The difference is clear. And the engineer gives us the curve that we superpose. And you can see the blue curve that is the initial one, the green curve that is performed at day 19, and the red curve that is performed at 1 month. And notice that the decrease of the area under curve is calculated at to minus 75% at day 19 and to minus 66% at 1 month. And this patient was effectively a good responder. Another example also of a female patient of 77 years old treated, I think, for a colon cancer, and the lesion was a parietal lesion. The target was a parietal lesion. Initially, here is the image on 2T, and enhanced at about 90% of its surface. The control at day 14, and the control at 2 months. The same aspect was noticed at 1 month. Same size, same vascularization. When we try to get the curve, and we do some mathematics, we see that the decrease of area under curve is minus 2% at 14 days and minus 30% at 2 months. This patient was effectively a bad responder. European and French team are not the only that worked on contrast ultrasound. This team do this multicentric work about imaging biomarker roadmap for cancer studies, and concluded that area under curve, the reduction of area under curve at 1 month following anti-angiogenetic therapy, has been shown to predict freedom for disease progression and overall survival. More recently, published in 2018, when we are talking about upcoming imaging concept and their impact on treatment planning and treatment response in radiation oncology, we can see that there is a myriad of new techniques to evaluate the response. And here is contrast ultrasound, presented with the advantages of being a real-time, continuous imaging, compatible with targeted contrast agent, widely available, inexpensive, relatively safe, available for primary or metastasis, and also that can be used for characterization and ablation guidance. Currently, in our institute, we have about 143 patients treated are included in phase 1 studies trial, in which we are following with ultrasound. You can see here that there is different histological types and different treatments in use, and we are trying to push further our explanation to understand the mechanism and to find the better indication and to understand the physiopathology of what we have noticed. In this group, for example, you can see that the decrease of area under curve is clearly correlated with a better free from progression period. And when I tried to do a review of the literature, I noticed that from 2012 there were not really new parameters or new suggestion or new technique. All the studies that have been performed since 2012 went more in the way to confirm the usefulness of ultrasound in evaluation tumoral response. And become more focused. As I mentioned, the first multicentric study was performed regardless to the histological type. And now what we can see is teams are starting to do it more focused. Here, for example, with metastatic renal cell carcinoma in a group of 32 patients. And they conclude that MRI, CT, and ultrasound are complementary, and that blood volume, which is correlated to the area under curve, measured by DCES, was the only parameter whose change during early anti-angiogenic therapy predicted for overall survival and PFS. It also said that no significant correlation has been found for CT. The key point of this study said that CT, MRI, and ultrasound are complementary, but the most important for us, that the change in blood volume measured by DCEUS was predictive of OS and PFS, and that the baseline vascular heterogeneity by DCES had the strongest prognostic value for PFS. Almost same work, but this time on colorectal liver metastasis, and almost the same goals and same conclusion of the usefulness and the reliability of CUS in evaluating this patient treated with anti-angiogenic treatments. Another study recently published on August treating about ultrasound breast cancer with a combined study of MRI and ultrasound that seems to propose another parameter, which is rate in change of increasing intensity of enhancement of the lesion. Well, it's the only study I found with this criteria, and the group is 32 patients, but I don't know. In the era of artificial intelligence, the ultrasound is here. As you can see, as it has been validated, it's now used as a reference for other techniques. For example, here is a study of molecular imaging to predict response to target therapies in renal cell carcinoma. This study was performed on MRI, but the reference was US, was DCUS. All results have been compared to DCUS. Last, but maybe not least, about maybe the future, it's because of some critics for for variability in quantitative or qualitative techniques. Some teams are trying to work on numerical modeling of blood flow in tumor microvascularization in order to propose reliable and automatic models to analyze the results. And according to the conclusion, it seems to be hopeful study. Finally, I will conclude like this. DCUS is a standardized technique validated in multicentric study on the basis of a clear injection of one total dose of 4.8 millimeters of intravenous contrast enhanced agent with acquisition of 3 minutes of raw linear data after specific analysis. It allows different functional parameter analysis, especially related to blood flow and blood volume. And if we have to keep in mind only one thing, it's that is a reliable and proven parameter who is correlated to PFS and OS, which is the area under curve evaluated at 1 month with a cutoff of decrease of more than 40%. Finally, I want to say thank you for your attention, and I want to thank Professor Nathalie Lasso, which is my chief and my professor, and that introduced me to the bubble and introduced the bubble to me. And that's all. I hope I was clear.